This program is brought to you by Emory University.
Good morning and welcome to Emory Heart and Vascular Grand Rounds. I'm Dr. Gina Lundberg. I'm the clinical director of the Emory Women's Heart Center, and it's my pleasure to introduce to you today Dr. Sandra Lewis. Sandra has been a mentor to many women in the field of women and heart disease, but she's also incredibly active with advocacy and the ACC PAC, and she's going to bring us a great talk this morning, Incremental Changes versus Disruptive Transformation, COVID-19 and the Cardiovascular Medicine. Dr. Sandra Lewis is a graduate of Stanford University of Medicine, where she completed her internship, residency, and cardiology fellowship. She currently practices in Portland, Oregon, where she served as the past president of the Georgia ACC chapter there. She's a member of the clinical cardiology faculty of the Oregon Health and Science University and serves on the leadership team at Legacy Health System, where she's helped develop heart failure programs, women and heart disease programs, and Women's Health Leadership Council. She is the chair of the Political Action Committee of the ACC and chair of all section steering committee of the ACC. She's also a board member of the Oregon Medical Association Political Action Committee and actively engages in cardiovascular advocacy for patients and clinicians. This is really where we all know Sandy from the ACC, and she's had a huge voice at working with people on Capitol Hill and transforming medicine through advocacy and legislation. During her 30 years of practice, she's participated in landmark clinical trials with her research interests including congestive heart failure, cardiovascular risk prevention, cardiovascular disease in women and older patients, and disease management. These include the SAVE, Prove It, TNT, Jupiter, and CARE trial, just to mention a few. More recently, she authored the third American College of Cardiology Professional Life Survey, co-authored papers on sex differences in ischemic heart disease, the pregnant cardiologist, and career preferences and perceptions of cardiology among U.S. internal medicine trainees. And she worked with me on a white paper on heart centers for women, historical perspectives of formation and future strategies to reduce cardiovascular disease. She's currently the principal investigator on a grant developing team-based novel methods for heart failure care delivery. Dr. Lewis, we're so excited to have you with us today.
Gina, thank you so much. And as you can see, it's pretty dark here. It's 3 hours earlier. So I'm going to try to keep my eyes open. I also wanted to thank Dr. Wenger for asking me the provocative question, how does cardiology, with its history of incremental change, adapt to disruption, and encouraging us to examine this question? As Dr. Lundberg said, I'm in Oregon, and just to reassure you, we have not burned down. We are not at war. We did have some bad smoke sent to us from the fires, but otherwise we're in really good shape, and I invite you all when we can again to come visit us. And I'm so sorry I'm not in Atlanta with you this morning, but one of these days. So this morning, I'd like to examine the impact of what I call the three current pandemics: COVID-19, the economy, and social justice and unrest, and how they impact cardiovascular care, with disruption creating rapid transformation versus usual incremental change in cardiology. Cardiology change is traditionally very slow. Thinking back to 1975, an angiogram at Stanford Hospital, where I trained, was a 5-day event. Day one, admit the patient. The medical students and residents worked them up. Day two, present to the attending. Day three, left heart cath. Day four, coronary angiography. They were split because we had radiologists doing the coronary angiography. And day five, present to the attending and make decisions on care. The phrase guideline-directed medical treatment did not exist, nor did formal guidelines. 45 years later, clinical cardiology research strides take for granted the coronary care unit, the acute interventional cath lab, the guideline-directed therapy for heart failure, coronary disease, lipids, and on and on. However, adoption of guideline therapy has always been slow, sometimes painfully so. The convergence of the three pandemics, COVID-19, economic disruption, and social justice unrest has upended the usual slow, incremental change we expect with unparalleled disruption, creating opportunities for transformation. In the three domains of cardiovascular medicine, academics, clinical care, and research, incremental change is the norm. Leading cardiovascular medicine through transformative change poses unique challenges and opportunities. Innovation from disruption may bring traditional leaders along, while other forces of disruption may cause reevaluation of traditional standards. Some disruption will lead to permanent transformation, while human nature and thoughtful review may favor return to the way it was. It's hard to remember the days when we might have traveled nearly 20,000 miles from home. Today, we hardly travel 50 miles without trepidation. The rumble of change must have been in my mind in February. I was supposed to travel with my husband to Saudi Arabia and London, where he was speaking. We would stop in Egypt to see the pyramids, and our flights were booked through New York for the most reasonable airfares. We were to change planes in Rome on our way to Egypt. I became nervous and risked the unhappiness of my husband and the loss of an opportunity to see a new part of the world, but I refused to stop in Rome. I told him I would travel as planned to New York, but stay there while he went to Saudi Arabia and meet him in London. I bought a lot of food to freeze: Clorox wipes, gloves, masks, and Purell, big bottles of Purell. I think I still have a full one. I may be the only person in the world. And so I clearly had a sense that something was cooking. By the time we arrived in New York in early March, COVID was accelerating in Europe, raging in China, and my New York flight on March 7th was the last destination I would travel for a long time, although I didn't realize it at that moment. We did a lot of walking, but didn't ride the subway or attend theater, a real change for us in New York. This crowded area is the New York Armory. It's located on the Hudson River. The weather was nice for early March, and as we walked to the Armory, where the Armory show featured representation from 32 countries and a total of 183 total galleries. I cringe as I think back on enjoying the art and discussing works from the gallery owners from around the world. And I wonder if that was an early hotspot. Thursday, March 12th, we crowded into this Upper West Side bar for dinner. Elbow to elbow tables were the norm here. Crowded spaces in bustling restaurants, so many that will never reopen. We headed back to Portland on March 14th. The plane from JFK was crowded with European travelers as we were shuttling down, it was a time when we were shutting down the travel from Europe. And Americans were afraid they wouldn't get home if they didn't come right away. I had alcohol wipes and gloves, but I don't recall if I wore a mask. Back in Portland, we quarantined for 2 weeks as New York was blossoming with its early COVID infection. I don't know if you remember when it was announced that the Bay Area counties were enacting shelter-in-place orders. It seemed so weird to me. It just seemed impossible. And these three pandemics have become the story of the last 7 months. The country shut down. Cardiology care faced inconceivable disruption with critically ill patients that my colleagues tell me were sicker than they've ever seen. One friend told me she needed to learn ventilators for dummies, and jokingly that she'd become a pulmonary critical care physician caring for the desperately ill New York patients. Millions of Americans became unemployed, and children were kept home from school, causing food insecurity, fear, and hunger. This bottom right are food lines, cars in food lines, winding miles. The increased awareness of the deaths of Black Americans by police fueled social disruption, complicated by stark economic awareness. Social unrest across the country evolved from peaceful marches to violence and smoke. Academic medicine, with its pillars of education, research, and clinical care, has been disrupted by these pandemics across all areas. Tradition permeates academic cardiology, is self-sustaining, reinforcing and rewarding of the status quo. Motivation to change involves questioning time, resources, ideas, passion, values, and expertise. Although possibly born from disruptive innovation and scientific inquiry before the slow learning, evidence-based change with feedback and often personal input of physical, mental, and emotional energy really evolves slowly. Teaching in cardiovascular medicine is a lifelong endeavor with cautious adaptation of scientific learning, guidelines, clinical research, and techniques, and all of these have been transformed with COVID-19. In March 2020, as the Chicago McCormick Place Convention Center became an emergency hospital, it became clear that the American College of Cardiology annual scientific sessions could not proceed as a meeting. We were concerned that it would be canceled. How, with just a few days, could a meeting proceed? However, stunningly, nimble meeting planners, speakers, and members converted to a virtual platform. The attendance broke all records, portending months of shift to virtual meetings. Zoom, WebEx, platforms quickly developed for live and recorded sessions as we are today. Serially, the European Society of Cardiology Conference, Heart Failure Society of America Annual Scientific Meeting 2020, and the American Heart Association meetings became virtual. These are 3 screenshots from presentations at ACC 2020, with pre-recorded sessions moderated by live panels and chat room questions. The presenters sustained the attention of attendees virtually. Although the energy created by in-person sharing of ideas is absent, ease of joining meetings brings diverse and expanded audiences to educational opportunities. This transformative change will be seen in hybrid meetings for large and small meetings going forward. Yet to be determined are financial implications of these changes. Dr. Lundberg and I were talking about this earlier. Will the fee structure and industry support enable survival of professional scientific organizations? As with our session today, we became virtual learners. I wish I was in Atlanta this morning. Teaching and training programs likewise underwent a 180-degree reversal. Whereas for several years, the sage on the stage had been incrementally replaced by small group teaching, case-based discussions, and a more participatory classroom experience, online classes appeared in days with many students experiencing Zoom overload. Faculty received crash courses in online teaching with the challenge to make education participatory, leading to creative solutions. Lloyd Minor, the dean of the Stanford University School of Medicine, noted unexpected benefits from online classes. Quote, "We're seeing a lot more participation from students in the class, and they're getting answers to their questions in real time rather than having to wait for the end of the class. I think it's a much better educational experience. Our students are telling us that. And by the way, the attendance at virtual lectures is higher than the attendance at the in-person lecture was." The next two slides highlight the impact on our fellows. From full PPE in the cath lab to hesitation to take COVID infection patients having cardiac symptoms to the cath lab, from halting of all elective procedures to limitation of clinical exposure, the impact of pandemics on direct clinical teaching represents greater disruption with only partial transformation. The trainee in a virtual clinic may miss the nuance of physical examination or patient interaction. Hospital rotations have both paused and accelerated. Some senior cardiology fellows found themselves functioning as attending physician in ICUs. Those on console or catheterization rotations found patient volumes markedly decreased. Most negatively impacted was clinical teaching, both at bedside rounds, the bedrock of clinical training, and in procedural skills. The limitations of team-based patient contact were requisite for safety, but they really impeded ward rounds, discussion, and honing of physical examination skills. Procedural teaching and learning suffered from limitations of access by teacher and students and will likely need remediation. Here you might see some Emory trainees. Education of the cardiology trainee faced both the uncertainties of the clinical experience and the interruption of formal requirements of fellowship, not to mention the difficulties of finding that first job. There were definite pivots from opportunities. Daily formal teaching sessions may adapt to the virtual model. Excuse me. Opportunities for transformative change in cardiovascular teaching will allow innovation in learning modules, clinical care, and knowledge adaptation. I can see 3D mannequins that might be programmed to represent clinical cases. Challenges to availability of routine didactic sessions and transformation to virtual learning has galvanized opportunities for experimental teaching modules, distant sharing of sessions, flexible access with repeat viewing opportunities, and standardization of materials. We've touched a bit on hospital clinical care, but the outpatient care with shelter in place presented monumental challenges. Telemedicine and innovation burst upon the American healthcare system, but it was made possible only after years of incremental change with the development of our electronic health records. As much as we may not love them, they provided the base for us to move forward with innovation. The interface of available remote access to patient records, virtual internet and telephone face-to-face interactions, and nimble adaptations by clinicians and our telehealth support staff allowed quality care delivery to quarantined high-risk patients. Virtually all of our cardiovascular patients fit into that bucket. Cardiovascular patients with pre-existing conditions unwilling to venture from homes for routine or emergency care brought clinicians and hospitals together to implement that virtual care clinic overnight. The transformation change from the pandemic brought unprecedented advocacy from clinicians. I know Gina highlighted my role in advocacy. I can tell you that there were stunningly rapid changes in insurance and governmental regulations, which allowed us to participate in telehealth visits. There were over 12,000 letters to Congress from ACC grassroots efforts, which underscores the impact of the cardiovascular community, your response to this disruption. However, rapid approval by CMS and insurers, first for visual virtual visits and then for audio-only virtual visits, is temporary. Ongoing incremental advocacy will be necessary and important to allow these transformative changes to become a platform for novel, innovative clinical care. The potential for telemedicine here with the virtual physician popping out of the computer, the stethoscope coming from the smartphone. These changes don't happen without creative minds, implementation, and advocacy. Temporary waiving of Medicare restrictions and HIPAA requirements by Health and Human Services allowed practices across state lines. The use of virtual visit platforms improved rural and new patient access without the requirement of prior relationships. Older adults adapted surprisingly well to the new norm, grateful to avoid travel to appointments. However, internet access challenged vulnerable populations, often limited those to telephone visits only. For non-English speakers, virtual visits often proved problematic, with interpreter services difficult to integrate. Nonetheless, routine ambulatory care visits and visits for medication titration have been forever transformed, with vast opportunities for disruptive innovation, such as extending current webcams, allowing limited physical examinations, creating holograms, measurement devices, and wearables to better mimic the in-person visit. And I hope you will join us today and tomorrow as we take our message to Congress to extend payment for telehealth visits, one of the key asks of our ACC legislative conference, which is going on today and tomorrow. I want to share some analysis of the impact of these changes on economic pressures as we consider the three pandemics, COVID, the economy, and social unrest. These are data from McKinsey looking at healthcare costs and COVID-19. As of August, there were 58 million jobless claims since March. And although the jobless rate dropped slightly this week, it's felt that this is mainly from women dropping out of the workforce to be teachers, housekeepers, and full-time mothers. The federal deficit is leading to debt exceeding the size of our economy, and states are faced with significant budgetary shortfalls. States, unlike the federal government, cannot operate on a deficit. Why am I adding this to virtual clinical care? As we advocate for the future for continued virtual care, we must understand that visual virtual visits leave vast portions of our patients uncovered. Not only do about 10 million people have no access to broadband, many of our older cardiovascular patients are unable to use video care. Either they have no computer, no smartphone, or just unable to utilize the technology. This is both an opportunity and challenge for ongoing cardiovascular care and innovation. Then in 2019, 11% of consumers used telehealth, compared to 2020, 76% expect to use telehealth going forward. The huge impact on health systems and insurers make telehealth a key area for advocacy and innovation. Looking at acute care. Well, we spoke a bit on the impact to fellows and training of changes in the acute care delivery in the hospital. Let's look at our patients. For more acute inpatients, the challenges increased. Family visits were curtailed or eliminated. Patients were dying alone. Healthcare professionals were almost unrecognizable in their PPEs until some began wearing a badge with a photo for patients to see. Limited staff and visitor contact with acutely ill patients increased their sense of isolation, and nurses in many settings rose to the challenge of using smartphones to communicate with the world outside of the ICU. Cardiovascular intensivists developed teaching modules to care for the COVID-19 patients with lessons for remote intubation, proning, and EKG QT interval monitoring. Daily EKGs was exposing one more person, one more staff to direct contact with the patient receiving hydroxychloroquine. A tragic result of patient fears of emergency room infection exposure was decreased hospitalization for acute MI and stroke. Rather than a transformative change, the incremental development over the past 5 decades in acute coronary care and stroke were lost as patients self-quarantined despite symptoms to avoid exposure to COVID-19 in the emergency rooms. I know we had a no emergency room rule for our family for minor things, and we weren't alone. I want to shout out at least one of the many innovations here at Emory from innovative research spawned by disruption. This is a joint creation between Emory and Georgia Tech. They created a barrier protection device for intubation to be used during COVID-19 to limit the exposure of the intubating physician or staff. This is an empty lab. What's happening with research since March? Don't know. Research was the most vulnerable domain to incremental disruption, with queries built on previous findings. As COVID-19 sent shockwaves through the research world, it created urgency for study and understanding of the diseases, its course, and treatment. The NIH and FDA moved from their usual snail's pace for approval and funding to warp speed with COVID-19 related research applications and requirements abridged. But an acceleration of development of tests and therapies, enthusiasm often overpowered reason and rigor. Early publication of unvalidated antibody tests created misinformation and confusion, highlighting the need to emphasize safety and scientific rigor. Public-private partnerships became the norm. No longer was industry a pariah, but a valued partner in the search for diagnostic treatments and vaccines. This is a story often repeated. Kathleen Beeson is a 6th-year graduate student at OHSU, Oregon Health and Science University, was trying to complete final experiments for her PhD on her way to becoming a postdoc at Harvard Medical School. She was given a 1-week notice of lab shutdown. Scientists have transitioned from long hours in the laboratory to working from home. This abrupt halt to research has left a lingering sense of disorientation. She said, "We were in a race to finish experiments, collect any data that we could, and get the lab prepared for a minimum of 6 weeks of shutdown." Another empty lab. Basic laboratory researchers faced unique challenges as shelter-in-place orders suspended or slowed ongoing studies. Knowledge from research paused mid-course, was delayed, or lost. Homebound scientists faced childcare and teaching responsibilities, slowing their academic careers. Women scientists faced selective disadvantages. With brakes on research laboratories and limits to those allowed to enter the laboratories, we may have lost a generation of young scientists. Ongoing projects were stalled, while opportunities opened for COVID-19 related basic research, with funding and focus responding to the transformation. How will young trainees, the graduate and undergraduate students now barred from laboratories, be excited by the latest turn in their research, ask the next question from their mentor, be motivated to write the next grant toward a career of scientific passion? Will the abbreviated virtual format of major scientific meetings obviate networking intrinsic in such settings? How will the scientific community address this disproportionate effect of quarantine on women scientists who became teachers, housekeepers, playground instructors, in addition to their remote scientific endeavors? Will early careers survive this disruption? Will academic institutions pause the traditional tenure track? These are only a few of the educational opportunities created by such groups as the American Heart Association, the American College of Cardiology. Tools enabling clinical care during COVID gave rise to shared research. Cardiovascular societies created platforms for sharing of data and concerns, and webinars were immediately available from Chinese and Italian colleagues, providing early input for the treatment of our sick patients. Journals expedited publications of COVID-related materials, condensing the review process to days from the usual weeks to months. And here you see, we lean on Dr. Fauci to guide us here at a Harvard Medical School Grand Rounds. The FDA in March issued guidelines on the conduct of clinical trials of medical products during COVID-19 pandemic and updates them regularly. As clinical scientists rush to learn about the virus and possible treatments, clinical research rules were disrupted. Remote informed consent was enabled, a change embraced by researchers and patients alike. If this becomes permanent, it will change research infrastructure for years to come in a positive direction. The participants' burden is increased by current requirements of a separate in-person visit for informed consent and initiation of a clinical trial. Clinical investigators may operate with the new rules remotely from research subjects, thereby increasing the pool for participation. This is important. The ability to conduct these visits virtually may mitigate some of the underrepresentation of women, racial and ethnic minorities, and older subjects, giving us a better idea of the results of our clinical trials on a broad base of patients. Vaccine science, big data, and artificial intelligence are key leaders in the COVID-19 research. Search for clinical responses to existing medications for critically ill patients, such as hydroxychloroquine, dexamethasone, and famotidine, caused endorsement before data were available. While big data presented the potential for rapid review of outcomes and adoption of changes in care, pressure on renowned journals to publish these data is fraught with exigencies of urgent need for clinical research versus established incremental analysis, leading to publication of fabricated data. Other challenges came when established clinical trialists drew from their networks to organize randomized trials, but found patients unwilling or unable to join studies, which might require leaving home for visits. As with basic laboratory studies, ongoing clinical trials faced other barriers, losing critical follow-up of randomized patients, disrupting data collection, and possibly voiding the validity of findings. And you recall that the Lancet and New England Journal both had to retract COVID-19 studies, including one that raised safety concerns about anti-malarial drugs. For other scientists, disruption presents transformation and opportunities for innovation. Characteristics of COVID, including thrombosis and myocarditis research, are accelerated by cardiovascular scientists. Other scientists are studying antibodies, they're growing mini lungs, they're developing novel vaccines, creating rapid and mobile testing platforms, developing Bluetooth masks, and on and on. And healthcare delivery may be the area of research that's best positioned for transformative change. Telehealth challenges with nimble device and informatics development are spawning vast new areas of research. Well, going back to the impact of society on our cardiovascular response to the pandemic. This slide shows 3 of the simultaneous social challenges of the pandemic. A march on Washington. In the lower left is a family march in Portland, where our marches went on far too long. and the deterioration and tear gassing of a DC demonstration. The impact of the three pandemics on cardiovascular care seen through social change is both incremental and transformative. It's impossible to separate the current viral pandemic from news of police violence, issues of social injustice, peaceful demonstrations spiraling into rioting, unemployment, illness, fear, and a deep national history of inequality. The social determinants of health, while well recognized in the US healthcare system, inform the transformative potential as society acknowledges the disproportion of COVID-19 deaths in African Americans and Hispanic communities. This is a slide of lines. Lines of cars hoping to get food from food banks, which cannot feed the masses. Huge lines of symptomatic New Yorkers trying for hours and days to be tested for COVID-19 in the poorest neighborhoods. And lines in the ICU at NYU Langone with triage to intubation because of insufficient ventilators and other equipment. Unemployment, hunger, and social unrest have incremental impact on cardiovascular health in at-risk communities. Vast increases in unemployment accompanied by loss of health insurance push vulnerable populations deeper into poverty. Those with crowded living situations accompanying poverty are more vulnerable to viral transmission, unable to social distance from those infected. These have become the face of the social determinants of care on public media. With disruption in society, media engagement of COVID-19 was inevitable. Public media provided a science platform, positive, in educating about the importance of underlying cardiovascular disease for outcomes, introducing words such as epidemiology, randomized studies, and disease transmission to general parlance. Science and evidence-based likewise entered the public discourse. However, as with hydroxychloroquine, suspicion of science and underlying human need for urgent answers rather than incremental study remains a challenge. Media response to non-scientific narrative is exaggerated by the disparate political pressures of our current social milieu. Political influence on trusted national scientific organizations, think NIH, CDC, FDA, it's engendered conflicting pronouncements, challenging national and international credibility of these institutions. Mixed messaging and politicization of public health recommendations further deepen barriers to acceptance of traditional science-based recommendations. And this weekend, we saw our president receive non-approved investigational medications, furthering the divide between science and hype. So I wanted to take a moment to share with you this screen. This was Dr. Wenger's 90th birthday party that we had. I was honored to be part of the group of people from around the world who look at Dr. Wenger as a mentor and sponsor. Happy birthday, Nanette. I wish I had been able to see you in person in Atlanta today. So the confluence of COVID-19, its impact on cardiovascular medicine, the economy and social unrest really converge to present unique opportunities for transformative change in academic medicine, clinical care, and research. However, fundamental challenges to the development of treatments and cure for the virus, decimation of the economy while isolating and limiting normal activities, and the deeply rooted social injustices laid bare during this time are going to require both incremental and transformative change to meet the disruption of COVID-19 on cardiovascular care and heart health. Thank you for your attention.
Thank you, Dr. Lewis. That was an excellent review of a lot of stuff that's happened in a very short period of time, and really very reflective on all that we've gone through. I'm going to open it up now to a Q&A. For those of you who want to participate, please write your question in the chat box. And I'm going to start with a question, Sandy. In 10 years, when this is all behind us, what do you think will be the number one change that we saw, that we embraced and continue to do in 10 years?
I think that healthcare can't go without a touch, but I think that a lot of healthcare is going to be assisted by the ability for us to do so much of our healthcare remotely. The innovation from devices, from the virtual. I remember seeing a demonstration of holograms and how the hologram could bring the clinician to bedside without being there, using an aid to help with that. I don't think we can imagine the scientific changes we're going to be seeing in IT and creative developments, toys.
So I have another question or comment. We have several satellite clinics with Emory Heart and Vascular. Several of our physicians go down to South Georgia, to Columbus, Georgia. Myself and about eight other physicians go to a North Georgia clinic in Hiawassee, and it's right on the North Carolina border. So quite a few of those patients lived in North Carolina, which was out of state, that had issues for telemedicine. But as you stated, many of those patients don't have a smartphone, don't have internet, don't have a laptop at home. And so we were just using telephones to communicate with them. I know I've heard of programs like in London where they would send a box to the patient with an iPad in it and things to check the blood pressure and to make these appointments for lower income or people who just have problems with it available. Do you see us moving into a direction to extend out the telemedicine to those who don't have services? Or do you think it's just going to get back in the office and we're not going to go beyond that level?
Well, as I sort of implied in my talk, to me, that's a huge, important ask going forward. Right now, CMS is looking at ways of extending telehealth, but the current bill that's available is only looking at video virtual visits. I think our advocacy for our patients is going to require that we extend the realm of care into our most vulnerable population. That map with the green dots, I think really says it all, that we have the opportunity to make the disparities in care even worse.
Dr. Lewis, we have a question from Dr. Pooja Mehta asking you to comment on the amount of telemedicine use among private practice physicians. You yourself are private practice, and how many of them have switched to telemedicine?
Well, I actually am employed by a health system now. I was in private practice for a long, long time. But I think that they've adapted as long as they have the infrastructure to be able to access their patient records remotely. The telemedicine, I think, has been adopted really across the board because, well, first of all, during the shelter-in-place orders, we really couldn't do anything but telemedicine, and our patients really like it. They don't want to leave home; they're terrified. So, and it's being paid for. The interesting thing is that that a lot of the private practices have been at least not destroyed by this because of the same kind of support that came for small businesses everywhere. So they received small business support from the PPP, and Medicare has worked with people to advance payments in a more stable way. So the private practices are incredibly vulnerable. They have staff, they have people that they want to keep paying or may need to let go because there's no money coming in. But in general, I don't think that there's any less adoption of telemedicine by the private practitioners. Big challenges, just like the restaurants, but using telehealth.
We have a question from our division chair, Dr. Robert Taylor. He wants to know, how can we better support our faculty with children at home, often doing remote learning? And as you pointed out, this disproportionately impacts female faculty members with negative impact on career advancement, compensation, etc.
Gosh, Dr. Taylor, that is such an important question. I worry about that. As an old cardiologist with grown children, I have the advantage of being able to sit at my dining room table and not be bothered except by my puppy. I think that this is going to be a challenge that we're going to have to dig into, and I hope that our academic institutions will work together to provide leadership support as we hopefully will come out of this at some point, transition support, and help with the tenure track. I worry about the time basis of tenure tracks as we move forward.
Do we have any other questions? One thing we are doing at Emory, as the Department of Medicine, School of Medicine has the Emory Women's Alliance for Medicine and Science. And we are putting together resources on the website there at Emory University for childcare options and some of those things. It's a small but honest investment. We're trying to help. We are very aware that the young physicians, men and women, with the kids at home and the childcare situations and the schooling online, are really struggling the most with this. And that's one thing that the ACC Women in Cardiology is trying to address as well, as helping these women deal with these situations. So it's highly impactful, and will probably have long-term impact.
You know, I think one of the most important lessons that I keep reminding people of is that my generation used to say, I can do it all. And I think we really tried to do it all. On the other hand, I think it's for the clinician well-being, it's really important to forgive yourself and say, yeah, maybe I can do it all, but not all at once.
Great words of wellness wisdom there. Thank you. Okay, well, if anyone else has questions, we have another minute or two before we need to drop off. Got several comments of great presentation. I think it's really impactful for us to look back how much we've accomplished since March 1st, and you've done such a nice job of that. And I know those of us who worked in the late 80s and early 90s were impacted so much by the age patients and what all went on with them. And that was a very transformative time. And certainly this COVID era will be something we all remember for many, many years.
May it become a memory.
Exactly.
Well, thank you all. I'm honored to have been able to share this, and maybe we can do a rehash as we come out of this in the next 5 years sometime in person.
And Dr. Taylor says, thank you so much for presenting this at 4:30 in the morning local time. We all appreciate your sacrifice. Hopefully you can get some sleep before the rest of your day. I know you have a busy day with the ACC Legislative Conference, and that's happening tonight. Any parting words for us, Dr. Lewis?
Yeah, you are our advocates, and you're your patient's advocate. The messages that we're taking to the Hill for our patients this week are incredibly important. And I just, again, invite you all to find out about what we're asking for our patients and for our colleagues, and join us. If not today, in the year coming up, there's a lot of really good advocacy support in Atlanta.
All right. Well, thank you so much, Dr. Lewis. Thank you.
And Dr. Lundberg, thank you.
The preceding program is copyrighted by Emory University.